Welcome to UOA On Demand. My name is Dr. Michael Liu. I'm an orthopedic surgeon. I specialize in surgery of the shoulder and elbow and upper extremity. Joining me on the call tonight, we have Dr. Jamie Monica, who is an upper extremity surgeon, also a hand surgeon. And we have Dr. Tim Leddy, also a hand and upper extremity surgeon. Thanks for being here, guys.
Pleasure.
Thanks, Mike.
So tonight we are discussing one of the most common things that I'm sure we all see in the office, which is shoulder bursitis. So oftentimes patients will come in complaining of shoulder pain, and it's oftentimes very difficult to figure out what is exactly causing the pain and to try to explain it to the patients, especially because we throw around these words like bursitis, impingement, tendonitis. Dr. Monica, can you just give me a basic high-level view of what the shoulder anatomy is in terms of the bones and the tendons and what a tendon is and what a bursa is?
Sure. So tendon is basically what connects muscle to bone. And tendons around the shoulder include the rotator cuff, which is a series of 4 tendons that surrounds the shoulder joint, which is a ball and socket joint. And the main role of the rotator cuff is to keep the ball centered on the socket, so then the bigger muscles around the shoulder, like the deltoid and the pec muscle, can raise the arm. There's also the biceps tendon that runs through the shoulder joint as well. So those are the main tendons that we often talk about. And then the bursa is a fluid-filled sac that sits between the tendons and the bone. And specifically, the bursa that often gets inflamed is a bursa called the subacromial bursa, and that basically is a fluid-filled sac that's underneath the acromion, which is the bone that's on the top here. So that bursa is between the acromion bone and then the top part of the rotator cuff. And the action of the bursa is believed to provide a smooth or gliding surface for the tendon so that the tendon doesn't get irritated by the bone that's right above it.
Mm-hmm. And so Dr. Leddy, Dr. Monica just mentioned the tendons and the bursa. So what is bursitis and what is tendonitis?
Yeah, so anytime we put an itis on the back of a named structure, it just means that that structure is irritated in one form or fashion, which means increased inflammation, vascularity, and the pain that can be generated from that. So if you have a tendonitis of the biceps tendon, that can be primary. That's relatively rare, mostly in throwing athletes. If you have a tendonitis of the rotator cuff, that's relatively common. That sometimes is in conjunction with a bursitis. It's actually sometimes difficult to tell the difference between the two. In many cases, you can have all 3 of those things involved. What sometimes is termed rotator cuff syndrome, and called rotator cuff syndrome, in my opinion, because it's usually the result of a weakened rotator cuff that has led to the impingement or crushing of those tissues between the humeral head and the acromion above it. Jamie did an excellent job describing how that is, and that will lead to some chronic irritation of that area. I often will talk about the relationship of the rotator cuff with the deltoid muscle, just to simplify it for patients. You can get into the weeds with all the different muscles that are in there. And I often will tell patients it's a bit of a tug of war between the rotator cuff centralizing the ball in the socket, and the deltoid is a very powerful muscle to move the arm. If you have a mismatch of the strength between those two, it's often that you'll end up with some dynamic impingement, which raises the humeral head against the acromion, squishing the rotator cuff and the bursa, and in many cases, the biceps tendon together, resulting in that inflammation.
Right. So I think you bring up a good point about the squishing of the bursa. And I think another example of bursitis would be olecranon bursitis at the elbow. So the very tip of the elbow, oftentimes patients will have a trauma or they rest their elbow on a hard surface and they get a little squishy golf ball on the backside of their elbow. And they say, hey, this is filled with fluid. What is it? And oftentimes it's inflammation coming from the olecranon bursa. And that's similar to what's going on inside the shoulder in the sense that you have inflammation inside the shoulder from repetitive irritation, degeneration, overuse, trauma, all these different things, and it leads to pain, inflammation, swelling, etc. So when patients come into the office, they often have pain, right, which is one of their primary complaints. But can you, Dr. Monica, tell me where the pain is, when they get the pain, some inciting events or activities that may cause the pain to be worse?
Yeah, so it is a very common presentation or diagnosis that we see in the office. Oftentimes patients do complain of pain, more so on the upper side of their shoulder. It's not so much pain on top of the shoulder, but more around this area, around the deltoid muscle. That's typical for where the pain radiates from either bursitis or rotator cuff issues. Oftentimes the patients complain of pain in that area when they're doing overhead activities. So raising their arm up over their head um, can pinch the bursa and lead to further inflammation and pain. So oftentimes overhead activities, sometimes twisting activities can irritate the shoulder. And the pain can happen with activity. It can happen at rest too. It's not uncommon for patients when they lay flat at night to have more shoulder pain due to bursitis or rotator cuff issues. So trying to distinguish between bursitis and a rotator cuff issue isn't so easy sometimes on exam. Patients still can have pretty normal strength with both conditions. So sometimes more advanced imaging is needed to distinguish between the 2.
Mm-hmm. Yeah, Dr. Monac, I think you bring up a good point, saying that the pain is typically more on the outside of the shoulder where the deltoid is, which is kind of lower down, as opposed to being up where the actual rotator cuff is located. So I think oftentimes patients will come in saying, hey, I think I have a problem in my arm and not necessarily in my shoulder. And you get to talking to them, you examine their shoulder, and it's lo and behold a rotator cuff problem. But the pain isn't where they would commonly think they should have shoulder pain. And I think that just goes to show that what you said is exactly right. The pain is oftentimes referred to lower down the arm where they wouldn't expect a rotator cuff problem to pop up.
Right.
So Dr. Leddy, can you tell me what kind of physical exam findings people may have when they come in with a rotator cuff problem? Say it's bursitis initially.
The presentation of shoulder pain and particularly with the rotator cuff can be variable. Many patients will come in complaining of pain that radiates down the arm to about the level of the mid-arm. Rarely does it go lower than that, but occasionally people will have referred pain lower down the arm. Pain is frequently related with activities, particularly overhead activities or lifting weight away from the body. It's also common to see people complain of the extremes of rotation being painful when they have tendinopathies or bursitis in the shoulder. And as we mentioned earlier, nighttime pain can be a very common complaint.
Right. And I think for people trying to put their wallet in their back pocket, that can cause pain. For women, when they're trying to clasp their bras behind their backs, that can cause pain as well. Oftentimes they'll come in saying, hey, I can't do my bra behind my back, so I have to clasp it in the front and then spin it around. And that's oftentimes the driving factor for them to come into the office for evaluation. So Dr. Leddy, talk to me about what you might see on physical exam. So the patient comes in, you're looking directly at their shoulder. Would you expect them to have bruising or redness or swelling or atrophy, all these things that you'd be looking for when you're doing your inspection part of the exam?
The purposes of shoulder bursitis, that's usually not something that's outwardly obvious. People don't show up with a big red swollen shoulder joint. That's different if they've got an AC joint that's inflamed. You can often just see that from across the room. The shoulder will be very inflamed right over the joint on top. And so in many cases, they're coming in just with the complaints alone. The physical findings will be, in some cases, limitations of the extremes of motion, although it doesn't have to be limited. And then in many cases, we'll find that they have weakness when we test the strength of the rotator cuff, and not necessarily because the rotator cuff is torn, it just hurts. And the pain of the exam can limit the ability for them to use their full force. And that's a telling sign as well.
Mm-hmm. Yeah, I think the rotator cuff can be a little bit tricky sometimes because there's a spectrum of presentations where people can have good motion, good strength, and a lot of pain, or they could have very little pain, but a lot of weakness. And they might have what's called a pseudoparalytic shoulder, meaning they can't raise their arm all the way on their own. But that would be more in line with the rotator cuff tear and not necessarily bursitis. But I think you're right. I think sometimes it's very tricky and you really have to get a good history, get good exam findings to see what exactly the problem is.
Yeah, you
So,
mentioned that
Dr.
paralytic
Monica,
arm. That often is the case with, a calcium deposit. So calcific tendonitis of the rotator cuff or calcium deposit in the bursa can be very debilitating and almost have a paralytic arm kind of a feeling, or pseudoparalysis of the arm. It's so painful.
right. And yeah, so that's a good point. So when you have a calcium deposit in the rotator cuff, we call that calcific tendonitis, which again, referring to what Dr. Leddy said about the itis portion being, the suffix being indicative of inflammation. So a calcium deposit is in the rotator cuff, it doesn't belong in there, it causes inflammation, and the tendon becomes inflamed. And oftentimes it can pop up out of nowhere. People have no pain going to bed one night and wake up the next day and they can't raise their arm. They come in, they get an x-ray of their shoulder, and they have a calcium deposit sitting in the rotator cuff that's causing a lot of inflammation and debilitating pain, causing weakness and just overall dysfunction and unhappiness. So Dr. Monica, say someone comes in with shoulder pain, who needs to get an x-ray of their shoulder? Are you getting x-rays on every shoulder patient or only some? How do you choose?
It really depends a lot on the history. Certainly patients with any type of trauma to the shoulder, or arm, I would get an x-ray. Also, I think if it's a long-lasting, condition where they come in and it's a condition has been present for, more than 6 weeks or so, I would definitely, think about getting an x-ray, just to make sure that the bones are okay, the joints are okay, and also, like you mentioned, there's no calcium in the rotator cuff. So I would say most patients I'm getting x-rays on, but if a patient comes in with, just maybe a week or two history of some shoulder pain without any trauma, and the exam is benign, then maybe we're not getting it. But a lot of patients we do end up getting x-rays on.
Dr. Leddy, same question to you. Who gets x-rays?
I find that in my practice, I'm often getting x-rays to rule out the potential for other problems. I'm often looking for that calcium deposit we were just saying, and you don't see it unless you look for it. Now, in all honesty, you can have a calcium deposit and not have any pain, but it's nice to know, when that person has so much discomfort that it can be related to a calcium deposit. I think also a simple x-ray can rule out a lot of the bad things that we see in orthopedics with a simple x-ray study, and it means that we've sort of crossed that T and dotted that I. So I agree with Jamie. If you have somebody that has, very limited number of symptoms, no real history of trauma, it just flared up, there's nothing wrong with some conservative management with that. You don't always have to run right off to an x-ray, but chronicity plays a role. I don't really think age of the patient really plays much of a role. Anybody can have a trauma. Anybody can have, a chronicity of pain that's worthwhile investigating. So along those lines, I think it's relatively rare that I don't get an x-ray.
Right. Yeah, I think a couple of points where it would be critical to get an x-ray would be, say someone did have a trauma, they got x-rays in the ER and they were reportedly negative, no fracture, no dislocation. But oftentimes in a trauma setting in the ER or in the urgent care, they're not doing all the usual x-rays that we would likely do in the office. And so they can oftentimes miss things. They might miss a calcium deposit, they might miss a dislocation, they might miss a fracture. So when patients come in having had a trauma and they're a little hesitant, understandably, to get another x-ray, I think if they understand why we need the additional x-rays, I think it makes more sense to them and they're more willing to go for it. So then, Dr. Monica, who gets an MRI?
So if I'm, concerned about the diagnosis of bursitis, or also sometimes we call it impingement, I hold off on an MRI and typically offer conservative management first, and to see how they do. And that's usually at least 6 weeks or so of either physical therapy or maybe an injection before proceeding with an MRI. So, and that's because typically I'll use an MRI more for surgical planning. If the patient has failed all non-operative interventions, then typically, I'm thinking about surgery as a last resort, and then we'll get an MRI for patients with bursitis or impingement.
Right. So I think I agree. I think if patients have not had non-operative care yet, and you're confident in your diagnosis of bursitis or impingement, and you want to start with a short course of maybe anti-inflammatories or therapy, I think it's not really worthwhile to get an MRI at that time because it won't change your management. Because even if you see minor fraying, partial tearing, or even a small full thickness rotator cuff tear, oftentimes based on the patient's age and history, maybe medical problems, you're not necessarily going to rush to the operating room anyway. So if it doesn't change your management, I think oftentimes it doesn't really benefit you to get the MRI right away because oftentimes it'll make the picture even more cloudy because you see the report, you see the images and you say, hey, look, I have bursitis, tendonitis, tenosynovitis, tendinopathy, and all these big 4 to 5 syllable words, and everyone's alarmed. But meanwhile, maybe with a little bit of therapy, anti-inflammatories, things will get better anyway.
Right.
So not to steal the thunder of the next question, but Dr. Leddy, what would you typically do for someone who you are very confident has bursitis? So they have had no trauma, they've had worsening pain over the past few months, negative x-rays. They haven't had any treatment yet, though. You're the first person they've seen for this problem. Pain when they're trying to raise their arm up, they can still perform their day-to-day functions, but they're just uncomfortable. Pain at night as well, and it's that classic pain over the lateral shoulder.
Well, like with the other things we do, there's sort of a stepwise approach to, how far each patient needs to go to achieve some relief of pain. As a general rule, my first place is to either get them on a well-designed home exercise program or with a physical therapist to work on strengthening the rotator cuff, which, in a very real sense, mechanically decompresses that impingement that they're having and can lessen the pain. The problem with that is it can take 6 or sometimes even 8 weeks before they realize the benefits of an exercise program like that. And as long as their pain level is not so high that they can tolerate that, and we might modify their other activities, limit some overhead stuff, and change the way they're doing some of their exercises or other activities. Those kinds of things can frequently lead to success without going too far up that pathway.
Mm-hmm. Right. So physical therapy, we mentioned, perhaps some anti-inflammatories. How often do you find yourself giving injections, steroid injections?
So again, that's another rung up there. So we talk about the use of oral medications, and frequently for me, I agree, it's a non-steroidal anti-inflammatory. It's rare but occasional that I will use a steroid for an oral steroid for a shoulder pathology. But as a general rule, it's non-steroidal anti-inflammatories and other pain medicines that can go along with that. So if they didn't tolerate that, and many patients have already tried that before they've gotten a chance to come to see us, they say, look, I've taken a bottle of Motrin already, or whatever anti-inflammatory of choice, and I haven't had the relief that I'm looking for. If their pain is really, bad, and that would include things like recalcitrant night pain, it's waking them up and they're not able to get back to sleep. Job pain, they can't do their job because of the discomfort. They can't take care of themselves or their family on a regular basis because of the discomfort that they're having. Those are all reasonable reasons to consider an injection. But I think we have to be very judicious about the use of injections. That's why we don't just throw them around all the time, is because they can do some bad things as well. So we want to be judicious with the use of those injections.
Sure. And then, Dr. Monica, who ends up getting surgery for bursitis or impingement with an MRI that shows no big tears or no full thickness tears of the rotator cuff? How often do you find yourself doing surgery for these types of patients?
I think it's rare. Tough to say a percentage, but I would say definitely less than 10-20% of these patients that come in actually need surgery, especially when the MRI, confirms that there's no tear associated with it. If it's just inflammation in the bursa, that does not respond to all the things we mentioned, oral NSAIDs, physical therapy, cortisone injection, and just has persisting pain, then that's the time we do consider surgery. There's one other imaging finding that we look for, and that's a bone spur underneath the acromion that can make that space between the rotator cuff and the bone even that much tighter. So if we see that on the MRI and they also have failed non-operative management, then that may be a good reason to maybe proceed with surgery.
Mhm. Yeah. And so what would surgery entail for you?
So surgery involves just it's an arthroscopic procedure, so which means we use a camera and small incisions, usually 3 incisions around the shoulder that are less than half of an inch. And basically we put it in the scope and first check out everything with the scope, make sure that there's no tear. Sometimes MRIs can miss small tears or other problems. So we make sure everything else is okay, and then go in with we use a shaver usually, which cleans out the inflamed bursa, and basically we remove that bursa, which will grow back in a healthy manner. And then also look for that bone spur, oftentimes shave down some of the bone underneath the acromion to just create more space in hopes of preventing a recurrence.
Mm-hmm. Yeah. And so then, Dr. Leddy, can you tell me if a patient has an early frozen shoulder versus bursitis, how can you distinguish between these two problems? Because oftentimes we'll both have pain, and the early frozen shoulder may not be super stiff yet. So how do you go about delineating between those two?
You really have to have your radar up to catch frozen shoulder early. I think in my hands, the way that I catch a frozen shoulder early in many patients is because I've warned them that it can affect another shoulder at a later time, and they're kind of on the watch for it, and they come to me and say, hey, I have very similar symptoms that I had in my right side when I got frozen. I saw a patient earlier today that I had seen with what I gave her the diagnosis of bursitis, and put her into some formal physical therapy in a home program, and she got worse. And her therapist, sent her back saying that maybe she needs an MRI. Well, she doesn't really need an MRI. She now has, a full-blown frozen shoulder, which carries with it a sort of a different pathway of recovery and success. But it is difficult, I think, early on. The inflammatory phase of the frozen shoulder typically encompasses the first 3 months. And I would say the first month to 6 weeks of that looks just like a bursitis. It can be very hard to differentiate. And of course, there's always that, what came first, the chicken or the egg? I think a lot of patients will form a frozen shoulder in response to having had a bursitis or some other form of irritation to the shoulder. And I think that's a fairly common route for people to go.
Sure. Yeah, just to touch on a few points that you said to keep it on your radar, I think it's a bit more common in women, certainly more common in diabetics, or people who have thyroid disorder, or people who have had some sort of prolonged immobilization, whether they were in a coma of sorts, or maybe they're in a sling for another reason. Say they had a broken wrist or broken elbow and they were in a sling for a long time. They might have a frozen shoulder that's very stiff as well. So Dr. Monica, can you tell me what your typical post-operative protocol is for patients who have an arthroscopic subacromial decompression for bursitis?
Yeah, so typically, so it's outpatient surgery. They're discharged the same day, and they go home in a sling. Typically, they also will have a block, which means their arm will be numb, so they won't have any pain when they leave the surgery center, but then the block wears off usually later that night. So we will provide some pain medication, usually just for a day or two. And then they transition to ibuprofen, Tylenol, and then the sling is really just for comfort. So as soon as they're comfortable, usually within a week, they're able to wean out of the sling, and then we'll see them in the office within a week or two. And then depending on how they're moving, how they're feeling, likely do some physical therapy, which could be as long as 2 weeks or even up to 6 weeks.
Sure. Dr. Leddy, do you put any restrictions on these patients after they've had surgery?
So I don't use a lot of restrictions for the standard subacromial decompression, the arthroscopy, just to clean out the shoulder, so to speak, and remove that bone spur that that Dr. Monica had mentioned earlier. The time when that changes is if you do identify something structurally that you have to fix. So the rotator cuff, if that's torn, that does carry with it a slightly different rehab protocol. I think there are times when we will consider doing a thing called a biceps tenotomy with or without a tenodesis. And that can also change the recovery time. It doesn't often change the restrictions, however. If I do a tenotomy, I'm usually letting those people move and get back to activities. Frankly, the sooner they get back to moving it, the better their results are going to be.
Mm. You know, I think it's important to touch on a point that Dr. Monica brought up when he said that oftentimes the MRI will give us a general idea of what to expect when you go into the shoulder, but you don't know for sure until you put the camera in, you look around, you poke around, you're able to probe the tissue and see exactly what's going on inside the shoulder. Because the MRI, it's useful, but it doesn't always tell the whole story. And so I think sometimes you get inside the shoulder and it's actually a bit worse than what you expected. Or say the MRI was maybe from 6 months ago and the patient didn't tell you they had another fall or something else had happened to their shoulder. And so you get in and it's a bit worse than you would expect. And so perhaps the surgery may be different as well, and therefore the post-operative recovery and rehab process. So to kind of summarize everything that we spoke about and bring it all home, we have a case presentation. This is a patient of mine who I saw not too long ago. And I just wanted to get your guys' thoughts on what was done and see if you would have done anything differently. So I initially saw him 5 years ago. At the time, he was 50 years old. He was a right-hand dominant male, and he was complaining of progressive left shoulder pain for approximately 1 year. Thought it would get better, never did. He didn't have a trauma. He's a healthy guy, no medical problems. He had pretty classic complaints of pain that was worse at night and pain that was worse with overhead activities. On exam, there was really nothing glaring. You know, he had no deformity. He had no atrophy of his muscles. He had good motion, but he had pain at the extremes of motion. He had positive impingement signs, meaning that he had pain with certain positions of his arm, but he had excellent strength. His x-rays were normal, so I diagnosed him with bursitis. Do you guys think that anything else comes to mind, or what are your thoughts at this point?
Yeah, I agree. I mean, that would probably be top on my list. You know, especially when you say that, you know, the strength was normal, range of motion also normal. So I'm definitely thinking about that.
Okay. So I gave him a prescription for anti-inflammatories. He started in therapy and he did great. No problems after that. So then we fast forward 5 more years to current day. And now he's 55 years old, still a right-hand dominant male. And he has a complaint of acute left shoulder pain and weakness for 6 months. So 6 months before he came to see me, he had a trauma. He fell onto his arm, had significant pain and weakness at that time, went to an urgent care. They got x-rays that were supposedly negative, and they gave him a prescription for anti-inflammatories. It didn't really help his pain. His weakness was still there as well. So he's still healthy, but again, his main issue is performing overhead activities due to pain and due to weakness. So on exam, still no deformity, still no atrophy. He still has good motion. He can move his arm all around. He has pain, but he can do it. He can raise it up. He can put it behind his back. He can do all these things. He still has positive impingement signs now that he did last time as well. The biggest difference, though, now is that he has weakness in forward elevation and weakness in external rotation. And as you guys know, these are important maneuvers for the rotator cuff. So I did look at the x-rays that he had from the urgent care, and they got appropriate x-rays, and they were negative. I didn't see any fractures or dislocations. So what are you guys thinking at this point? Dr. Leddy, what would you do? Would you get an MRI? Would you get some therapy? What are your thoughts?
Yeah, I think the time frame now is a little bit concerning because he didn't present for 6 months. That's a long time. If he had had a fall, 2 or 3 weeks prior, I think you could consider doing some conservative stuff. You have some time to work with there. So here we get into a problem with certain insurances give us difficulty with getting MRIs in some cases, but that would be my choice at this go round, at this juncture, would be to get an MRI of his shoulder to see what that rotator cuff looks like and see if there isn't a tear there that would need to be treated. In the absence of the clearance with an insurance program, sometimes they make patients go through a period of formal rehabilitation and physical therapy. Another thing that I have done in the past would be to do a selective injection of just a numbing medicine into the bursa, into the shoulder. And if that will improve their ability to resist those maneuvers, the strength of the rotator cuff is improved after that. It gives me a little bit more confidence to know that, okay, maybe it's just, some chronic inflammation and we can work through that. But this is a difficult scenario, but I would lean more towards the MRI for sure.
Sure. Dr. Monica, what do you think? MRI, therapy, injection?
Yeah, no, I agree with Dr. Leddy. I think the chronicity is concerning. A history of trauma, fall, as well as your exam was showing some weakness, kind of points more towards, a little more concern for the rotator cuff. So I would try to get an MRI. Again, as Dr. Leddy mentioned, we may not be able to get that approved without trialing physical therapy, but I would certainly try.
Sure. Well, the stars aligned and we got an MRI. So here we are. We are looking at two images from the patient's MRI. This is the left shoulder. So this is the humerus or the arm bone here. And this is the ball on top of the humerus. This is the socket known as the glenoid. So it's a ball and socket joint. This particular series is called the coronals, meaning we're slicing the patient like a loaf of bread from front to back. So like I said, the arm bone is here, their head would be up here, their neck and spine would be in this area here. They're kind of laying on their back, looking out at us. So the main finding on this particular image is that the rotator cuff is supposed to be attached onto this part of the arm bone here called the greater tuberosity. And we don't see the rotator cuff there because the rotator cuff has torn and has retracted back to here. So this is the rotator cuff here that is supposed to be attached to the arm bone here. And so this is a fairly large rotator cuff tear. On top of that, you can see he has a good amount of fluid in his shoulder joint. We call it an effusion. So that's the white area here and the white area here. And that's typically indicative of inflammation inside the shoulder joint that you wouldn't normally see. And so on the right side, we have an axial MRI from the same patient. So the arm bone again here, and we have the socket or the glenoid here. The patient is laying on his back and he's looking up at the sky. So another rotator cuff tendon is the subscapularis, which is in the front of the shoulder, and that's okay. His biceps tendon is not healthy, it's deformed. It's a little bit what we call subluxated, meaning it's not perfectly aligned inside this groove, and we'll see pictures later on of that. Next set of images, we have a sagittal over here on the left. And so we're slicing the patient like a loaf of bread from side to side. He's looking towards the left. His head is up here again. So this just shows that the rotator cuff is torn from here all the way back to here. And so that's a large, very sizable tear. And then the image on the right is another sagittal image. This is a little bit different than the one on the left because it's more to look for the muscles of his rotator cuff. You can see that the fat underneath the skin is a white color. So the fat here around his muscle shows that he may have some atrophy of his muscle, which speaks to the likely chronicity of the tear being a good 6 months from injury. But his other rotator cuff muscles look pretty good. So we spoke about the different options. 55 years old, he wanted to be active, was previously normal before this trauma, could lift his arm, could do all these different things and had no pain. And we spoke about the likelihood of having persistent weakness and dysfunction in light of this big rotator cuff tear. So we proceeded with surgery, which was an arthroscopic surgery. So as Dr. Monica mentioned, we put the camera inside the shoulder. And from here, the camera is in the back side of the shoulder. I do this surgery in what we call the beach chair position, meaning that the patient is sitting almost upright as if they're on the beach. So we're looking from the back of the shoulder. This is the socket here, the glenoid. This is the labrum, which is a ring of cartilage inside the shoulder. And you can already see that the labrum has some problems. It's very wispy, very frayed. It doesn't look 100% healthy. And then he does have some inflammation, which is the pink or the red that you see in these areas here. Next image would be the subscapularis that we saw before, which is this tendon here, and that looks okay. the biceps tendon, which we had alluded to before as well. So this is not healthy. You can see it's very frayed, very wispy, and that's likely from repetitive rubbing of the humerus bone or the humeral head on the tendon because the rotator cuff is no longer there to help capture the shoulder. So this view, we're looking at the bone here. This bone is not supposed to be visible from where we're looking from the top back part of the shoulder because it's only supposed to be covered by rotator cuff. So this instrument is put in from another portal to clean off the bone, clean off any tissue that's stuck onto the bone so that we can lightly remove a small thin layer of bone, and that'll allow for better healing of the rotator cuff repair later on. So this is the side view now. We're looking at the rotator cuff here, which is the pink, very inflamed tissue, and it's way, way back, far retracted. This is the bone it's supposed to be attached to down here. So we're not supposed to be able to see into the shoulder joint, which is this area here. This is where the socket is. This is the ball. This is the ball and socket joint of the shoulder. And we're not supposed to be able to see that because it's supposed to be covered and blocked by the rotator cuff. But because of his large rotator cuff tear, we're able to see directly into the joint. So we cleaned off the bone here. We took off a very thin layer of cortical bone, and this allows for blood products and marrow elements to escape from the bone to promote healing. We make another portal to put this guide into the shoulder, and this allows us to drill and place an anchor into the bone. So these anchors have sutures coming out, like these sutures here. And these sutures are made of essentially polyester or like a Kevlar material. So you see one here, we're putting in another one here. There's already one back here as well. So we use another instrument to pass the sutures through the tendon. So this is all tendon here, and the suture is now being passed through the tendon. And then we bring those sutures and we tie them over the top of the rotator cuff, and we pass them through another anchor, and then that will then secure the sutures on top of the rotator cuff back onto the bone. So we call this a double row repair because we had the previous anchors that we inserted and now this additional row of anchors as well. So this is the final product. So you see a crisscross kind of pattern of these different sutures that are coming down. This is the rotator cuff that's underneath the sutures and now being compressed back onto the bone. Another view, same thing, sutures crisscrossing, sutures over here. And then the final picture is the side-by-side kind of before and after. So again, we're looking at rotator cuff here. We're looking at bone here. We're not supposed to be able to see into the joint because the rotator cuff is supposed to be attached to the bone. And now on the picture on the right, the rotator cuff is now compressed under these crisscross network of sutures, and we can no longer see into the joint. So he's about a month post-op now. He's doing therapy, and I think he's going to do well. But time will tell. I think he's doing well, though. Would you guys have done anything differently? Would you have not done surgery? Would you have done injections or therapy or anything else?
I would have definitely operated on him, and I do think, you know, the tear morphology is important. The size and shape of the tear and the chronicity of the tear can help to sort of determine whether or not you want to do it arthroscopically or open. I might have leaned more towards doing this one open. Patients may, when they're watching this, may wonder, why are there so many different colors to this, you know, all these different suture materials. And it's so that we can keep track of which anchor is where. And when you're doing these arthroscopically, it can get very confusing very quickly. And so that's why there's all these different colors, so that we know which ones go into what place. And you know, when I do these open, it's a little less confusing. So that's one of the reasons why I will sometimes consider doing one of these larger tears open. But this looks very nice. It's a good way to do it.
Yeah, I agree.
Monica, would you have done anything differently?
No, I mean, it looks great. This double row repair that you did is really the gold standard for care for this type of tear, and looks like you got a great repair.
Yeah, and then to touch on his biceps tendon, we did what Dr. Leddy had referred to before, which is a tenodesis. So we released it and then sewed it back further down, and we removed the diseased portion of his tendon and sewed the tendon back down further in his arm, but in the normal pathway, so we still have good strength and a nice muscle belly as well. Okay, well, thanks, gentlemen, for joining on the call. And just in summary, so we spoke about shoulder pain and specifically shoulder bursitis. and how patients will present with pain typically over the side of the arm. It can be lower down the arm, not necessarily up at the shoulder or even in the shoulder blade, where oftentimes patient thinks rotator cuff pain may present. And patients can oftentimes have good motion, good strength, and good function, albeit with pain. So it's our job to figure out whether it's frozen shoulder, bursitis, rotator cuff tear, arthritis, all these different problems that can kind of mimic one another. So we talked about the physical exam findings, we talked about the need for x-rays, and how in some situations an MRI could be useful as well. We spoke about non-operative care in the form of injections sometimes, but usually therapy for sure, and perhaps anti-inflammatories as well. And then we spoke about sometimes people needing surgery and what they can expect after surgery, with the caveat that sometimes the intraoperative findings are a bit different than what the MRI may show initially. And so you have to change gears and be ready pretty much for whatever the shoulder presents to you at the time of surgery. So I hope this was informative for everyone. I want to thank Dr. Monica and Dr. Leddy for joining on the session tonight. If you have any questions or any concerns, or would like to make an appointment to have your shoulder pain evaluated by one of the doctors at UOA, you can find us on the web at uoanj.com.